Einstein famously said, God doesn't play dice with the universe. 350 years ago in France, playing dice gave rise to probability theory, and probability theory underpins the medical statistics that we use, and medical statistics underpin randomized controlled trials. And doctors, when they gamble with the drug dice that they're going to give us, depend on randomized controlled trials to tell them whether the gamble's safe or not. The question is, should we be confident in doctors' confidence? So let me take you to 50 years after the first medical randomized controlled trial, when a man called Don Shell took paroxetine because he was having problems sleeping. He had it for 2 days, and 48 hours after he began, he shot his wife and his daughter and his granddaughter and himself. His son-in-law, Tim Tobin, took an action against GlaxoSmithKline, and the person you see here on the right is Ian Hudson, who at the time was the chief safety officer for GSK. Hudson said, he told the jury under oath, that companies use evidence-based medicine and RCTs to evaluate and approve their drugs. And he also said that their RCTs show that Paxil has no adverse effects at all. It can't cause you to commit suicide, and certainly can't cause you to commit homicide. The jury listening to him didn't believe his take on evidence-based medicine. They preferred evidence-based medicine, which was, it was obvious this drug had caused a problem, and they found GlaxoSmithKline negligent. In the longer run, however, Hudson's views prevailed. He became the CEO of the British drugs regulator, MHRA, and his views are entrenched or ensconced to the top of FDA and EMA and WHO. And views like that go back to this strange little man here, Ronnie Fisher, who was not a doctor, never ran a randomized controlled trial, and wasn't very good with medical evidence. When the evidence came out that smoking could cause lung cancer, Fisher poo-pooed it. He didn't believe it. Fisher was trying to characterize expertise, the kind of expertise that you and I figure we have if we were in a plane and 40 guys were being pushed out of the plane, 20 wearing parachutes and 20 not. We'd expect 20 dead bodies on the ground and 20 live bodies, the ones wearing the parachutes. Fisher said, yes, that's the expert view, but you know, chance could play a part in 1 out of 20. We admit that the expert's right if 19 out of the 20 guys without the parachutes died, but one could be blown by a strong gust of wind into a snow-covered tree and live, and this has happened. There are other things that could play a part. You know, some of the guys without the parachutes might have webbed armpits or webbed feet, so they fall slightly slower, and we can randomize to take care of trivial and inconsequential things like this, which if you're an expert, you know, there's very little that you don't know that isn't trivial. Fisher's expert was a bit like Robin Hood. He knew what he was doing. He could pierce an arrow that had pierced the bull previously 19 times out of 20. He was precise, he was accurate, and this was happening in the real world. In contrast to this, the trials that bring the drugs we know and love onto the market look much more like this. They're all over the place. Whatever we're doing with these control trials, it hasn't got much to do with Fisher's expertise, and maybe very little of what he was saying actually applies to the control trials that we're doing. The first medical RCT was run by a man called Tony Hill, and it reported in 1948. Hill was the man who put the link between smoking and lung cancer on the map. He didn't particularly like Fisher, and he didn't believe that randomization was something mystical that could control all confounders. He simply used it as a method of fair allocation in this trial. And I have to tell you, 3 years before Hill's trial was run, there was a trial in the Mayo Clinic that didn't randomize patients and told us more about the effects of streptomycin in tuberculosis than Hill's trial did. It told us that it worked, but people became tolerant pretty quickly, and they could have serious problems, like they could go deaf. So here's Hill, 20 years later, talking to a group of doctors about control trials, saying we needed to do them in the early 1950s because there were all sorts of claims being made about things that didn't work, and we needed to establish if something worked or not. But we don't need to do that now because we've had a ton of drugs since, antidepressants, hypoglycemics, antihypertensives, all of which clearly and obviously work and weren't brought on the market through controlled trials. We didn't need controlled trials for them. If controlled trials have a place, it may be in the ballpark of trying to decide which is the best of these drugs that work in class. But of course, there's no such thing as a best drug. There's a right drug for me and for you, which may not be the same thing. He said, randomization is not particularly important. Double blinds are not particularly important. If these things get in the way of a doctor being able to evaluate a drug, then you need to put them to one side. It's the judgment call of a doctor looking at a patient, seeing what the drug does, that actually counts. He also said, look, randomized controlled trials, or controlled trials generally give us an average effect, which may tell us nothing about how to treat the patient right in front of us. And he said there's a curiosity here, which is, if you listen to the people who are encouraging doctors to prescribe according to RCTs, it's pharmaceutical companies, not anyone else. But he said, randomized controlled trials are a good club to have in the golf bag when you've got something that you think it's not clear that it really works, and a randomized controlled trial can help us work out whether this one of the 1,000 things that a drug does could actually be useful. Now, there was a trial that had been done 5 years before that, which brings out Hill's point beautifully. It was done by Louis Lassagne, whom you see on the right, who did a trial of thalidomide, a placebo-controlled randomized trial of thalidomide as a sleeping pill, and showed that it worked. But this trial missed the nausea, the agitation, the sexual dysfunction, the suicidality, the peripheral neuropathy, all the things that this drug can cause. 2 years later, when the thalidomide crisis blew up, Lassagne was the person responsible for incorporating randomized controlled trials into a new Food and Drugs Act. And there was a curiosity here. One is, regulation generally is about keeping us safe, whether it's about food or traffic or at the stock exchange. Medicines are one of the few places, maybe the only place, where regulation isn't about keeping us safe. It's about, does this thing work? And actually, an emphasis on whether it works or not is not helpful for safety. The other curious thing here is Lassagne put in place the mechanism through which thalidomide had sailed beautifully. Now, I told you, or Hill told you, that by the end of the 1950s, we had a lot of drugs that worked wonderfully well, so well that we didn't need randomized controlled trials to prove it. Among these was the antidepressants. And the first antidepressant was imipramine, which is a much better drug than any of the SSRIs we've had since. It and the older drugs treat melancholia in a way that they don't. Melancholia comes with an 80-fold increased risk of people going on to commit suicide compared with you or me. So in a trial of imipramine in melancholia compared to placebo, we'd expect the suicidal events to look a little bit like this. This is a trial that would seem to show imipramine, whatever it does, can't cause people to commit suicide. But I need to tell you, a year after it came on the market, a bunch of experts around Europe were convened, and they said, this is a great drug. We're not going to need to use ECT anymore. It treats melancholia, which is beautiful, but it can also cause people to commit suicide. You put them on the drug and they become suicidal. You stop the drug and the problem clears up. You put them back on the drug and the problem reappears. So this drug that can cause people to commit suicide in a randomized controlled trial can look like it's doing just the opposite, that it couldn't cause people to commit suicide. Now, in contrast to that, the trials that brought the SSRIs on the market, the data looked more like this. And that was because these drugs are weak as antidepressants. They had to be given to people who are mildly depressed, who had no increased risk of suicide compared with you or me. So the risks from the drugs stand out more clearly. If you put imipramine into these trials as a comparator, which we did, the data for imipramine looks exactly the same. So we've got two sets of trials where imipramine seems to be giving exactly the opposite results. And this can happen in a situation where both the treatment and the condition cause superficially similar problems, which is true across most of the conditions we treat in medicine. These are not drug trials, that's what we usually call them. These are treatment trials. If you want to see what a drug does, unconfounded by the condition, you need to do a drug trial, which are the phase 1 trials that companies did. And in the phase 1 trials for SSRIs, they found that people committed suicide, they became dependent on the drug, they had sexual dysfunction. And of course, this enabled the companies to design the treatment trials, so these things didn't show up all that clearly. Now, I haven't quite said to you that there are more dead bodies in the active treatment arm of antidepressant and lots of other drug trials compared to placebo, but there are. So how come if more people are dying on these drugs, we say they work? Well, the answer is that we decide working on the basis of surrogate markers. And in the case of antidepressants, it's rating scales. And the most famous is the Hamilton Depression Rating Scale. And you see Max Hamilton here saying that rating scales like this standardize clinical interviews, which can be a good and a bad thing. Now, what do I mean by that? Well, if we're doing a research trial and I've recruited Lisa to the trial and I'm checking from the Hamilton rating scale, well, this looks more like she's the researcher and she's recruited me. But anyway, if we're on this rating scale, there's items for being suicidal, for being anxious, for your appetite, for your sleep, for sexual functioning, and all of which can be affected by the treatment and by the condition. And if Lisa asks me, have you been suicidal in the last week? And I say, yeah, I've tried to kill myself twice. She should be scoring 4. But if the score, or if she has a hunch that it's the drug causing this problem, the score should be 0. In a research exercise, however, she's not allowed score 0. She has to score 4. Randomized controlled trials have become algorithmic. They don't allow doctors in the course of them to make judgment calls, which is exactly what Tony Hill thought doctors should be doing in RCTs. So let me take you on to the James Webb Telescope here, which many of you, I'm sure, have thrilled to the imagery from it. 200 years ago, the instruments that astronomers had weren't as good as this, and often they couldn't actually distinguish if they were seeing 1 or 2 stars. And Gauss came along and said to them, look, if it's measurement error, poor telescopes, the errors are, the measures are going to distribute in a confidence interval. And if a new measurement falls outside that confidence interval, then you've got 2 stars. So this is a way to solve the problem people had 200 years ago. And it helped advance the telescopes we have to the James Webb level, which we now have. Confidence intervals rushed into medicine in the 1980s, as you see from this article here at the BMJ. And as you see from the list of experts on the right-hand side there of the screen, where most of the experts in medical statistics say that we should not be using statistical significance. Fisher's ideas about this don't apply in medical RCTs where we're not experts, we're estimating effects. And confidence intervals look a little bit like this. We've got 2 drugs here, both of which can kill you, let's say, the red drug and the yellow drug. And they tell us how precise the measurements have been in a controlled trial. And in the case of the red drug here, they're very precise. And we're also told that they give us an estimate of what the likely effect on the drug here. And the yellow drug looks like it could be more dangerous, but we don't know for sure. And the conventional wisdom is if we add a few more patients into the yellow drug trials, we'll get a more precise estimate. All of this is wrong, as I hope to show you, but I need to tell you that experts in medical statistics like Sander Greenland would say, look, confidence intervals is the wrong word here. We should be using compatibility intervals. And this comes out when you ask Ian Hudson, which of these 2 drugs should I take if I'm forced to take one? And he'd say, you take the yellow drug because we know the red one can kill you, but the yellow drug maybe can't. Sander Greenland would take the yellow drug, would take the red drug because it looks much more likely that the yellow drug is more dangerous. It's compatible with being more dangerous. And for 100 years, experts in this area have been saying to you, these are models, a bit like the modeling that was done during the COVID pandemic. It may bear no relationship to reality. You have to establish that the model is actually linked to reality in some way. And I'm going to show you that in these cases, it's not well linked to reality. Around 1990, there was a fuss about Prozac causing people to commit suicide. And Lilly analyzed the controlled trials, as you see here, in their depression trials and their eating disorder trials and trials in children and trials in adults and said, look, there's no evidence that our drug causes people to commit suicide. This is Ian Hudson thinking. Because 95% of the data isn't to the right-hand side of the 1.0 line, Lilly and Hudson are treating it as, well, there's no statistically significant result here, which means that we don't know that the drug is causing a problem or not. Sander Greenland and I would say to you, well, these are compatibility intervals, and they're all compatible with Prozac causing people to commit suicide. And the consistency across all the trials the company have done strongly suggests that there's a real problem here. But let me take you a little deeper into this data. Here's the distribution of events in the trials that brought these three SSRIs onto the market around 1990. And you see under the word screening, there's a week or a 2-week phase where people are whipped off the previous drugs that they're on, and they're put into withdrawal, and this is terribly dangerous, and a lot of people go on to a suicidal event or completed suicide. So when the companies sent the data from their trials into FDA and other regulators, this is how they sent the data in. They said, you know, people in the screening phase are on nothing. That's the same as being on placebo. Let's move these events down into the placebo arm. And they made some other interesting maneuvers here as well. Now, even when they did this, there was an excess of suicidal events on active treatment compared to placebo. This didn't come to light for about 10 years or so, and it particularly came to light when there was a fuss about children becoming suicidal on these drugs, and the companies were asked, you know, what the hell is going on here? And their response was, well, you know, we didn't hide anything. You've seen exactly what we did. FDA saw what we did. They didn't complain. Now, that's not actually true. There were memoranda from people working for FDA who said, this is breaching regulations. This is not right. It should be undone. But the senior hunchers in FDA took a different approach, which was they said, it's fine. And not only that, they used this manipulated data to make arguments that that placebo-controlled trials were ethical because there was no excess of suicidal events on placebo compared to active treatment. Now, why did FDA do this? In the early 1990s, they were liaising closely with the companies about these issues. Liaising criminally? Well, I prefer the idea of strategic ignorance on the part of FDA, who are bureaucrats who figured it's not their job to make medical knowledge. That should be doctors making medical knowledge, but they went missing around this point, leaving the companies to make medical knowledge, which they've been doing assiduously ever since. So after the issue about children becoming suicidal was cleared up, FDA decided to revisit all this and ask the companies to resubmit the data from their adult trials, not making the maneuvers that they had made before. And this is part of the submission from GSK to FDA, which I've summarized at the end. And you can see that actually the data here suggests statistically significantly that paroxetine causes people to commit suicide, which is a real problem for Ian Hudson, except randomization is going to rescue Ian and GSK, because GSK have also done 2 or maybe even 3 trials in people who have intermittent brief depressive disorders, and the data for that is here, and I've summarized that too. And the interesting thing is when you add the 2 sets of data together, all of a sudden paroxetine prevents people committing suicide. Now, the data has been separated out here, but I can tell you that everybody with IBDD could qualify for an MDD trial. And what you should see then is if you mix these 2 groups together, that the mixture, the heterogeneity of the 2 groups is going to hide effects of the drugs, either good or bad. And if you're really smart, you can use a problem a drug is causing to hide the same problem the drug is causing. And this happens, will have to happen in every medical treatment where we do an RCT that has been done in a heterogeneous clinical condition, which is depression, for instance, diabetes, dementia, breast cancer, or any other kind of cancer, Parkinson's disease, or any neurological disease, hypertension, back pain. Pretty well everything is heterogeneous. So we're not dealing with a situation where the confidence intervals are going to map very well onto the real world. Let me show you. The red curve here now is the MDD confidence interval, which is a real problem for GSK. The yellow curve is the combined IBDD and MDD trials. The conventional wisdom is you add a few more people into the broad curve you have there for the red drug, and you'll make the estimate more precise. Well, we've added less than 3% more people in, and we've got a much more precise estimate. But this precise estimate doesn't tell us that we know what we're doing. It says just the opposite. It's a demonstration of our ignorance. In terms of Ian Hudson, he could add 40 more suicidal events into the combined data set that we have here before he would have to admit that paroxetine causes people to commit suicide. In addition to the heterogeneity of the clinical conditions, there's a heterogeneity of drug responses. Let's say we gave Ian Paxil and he wakes up and can't easily get to sleep. And let's say we can clone him and get 20 of them. And you give me Paxil and I fall asleep and find it hard to wake up, and you can clone me and get 20 of me. And we run a controlled trial on all 40. The best estimate of what this drug does would lie somewhere on top of the 1.0 line, which means that a method of trying to distinguish between whether we're seeing 1 or 2 stars is ending up telling us that we're seeing no stars at all, which indicates that there's something about this issue about assuming too quickly that the model applies to the real world. And this brings me back to the James Webb Telescope. Generalizing with confidence intervals and things like that can move science forward, but good science from genetics to astronomy brings out individuality. The problem we've got in medicine is when we roll a drug dice, we're terribly nervous, we're gambling with people's lives, we want to be as objective as we can. We feel our judgment may not be all that great. And we've got a fetish for numbers and have turned, as we think, to chance to control bias, when the scientific method is all about using bias to control chance. Now, I should make one more quick point. Recently pointed out to me that one of the things that happens when we talk about generalization and universality, and people think that's what we get from controlled trials, when you give Roche's anti-malarial Lariam in Peru or whatever, you get people going psychotic, which this drug can cause, and they express this in all kinds of ways. And what you've got coming out of some of the things that happen there when anthropologists or sociologists go in to look at, they talk about local languages as opposed to the universal and global language of the drug company, which says our drug can cause no problems. The idea that randomized controlled trials were the best way to decide whether a drug causes an adverse event or not appears in the early 1980s, as you see from this quote here. And the person you're seeing there on the left is Louis Lassagne, a little bit older, who is saying, this is all wrong. Randomized controlled trials are not the sophisticated and scientific way to see if a drug causes an adverse event. Sophisticated, perhaps, in the sense of if we sophisticate wine, we adulterate it. The way to establish whether a drug is causing an adverse event, he's saying, is through evidence-based medicine, not through what was about to be called evidence-based medicine. And a great example of what he was referring to came about 7 years later, when 3 Boston clinicians, Marty Teicher was the first author here, reported on 6 patients becoming suicidal on Prozac. They gave them the drug, people became suicidal, they took the drug away, and the problem cleared up. They reintroduced the drug, the problem came back. And in particular, they had patients saying to them they could distinguish between the suicidality caused by the drug and the suicidality caused by the illness. This article nailed the fact that Prozac can cause some people to commit suicide. And about 20 other groups during the course of the next year reported the same thing, including me. Lilly's response was an article at the BMJ, which essentially creates evidence-based medicine, where they said, look, there are all these anecdotes out there from people like Teicher and Healy, which are, they're awfully sad stories, but they're just anecdotes. And the plural of anecdote is not data. Well, the original phrase is the plural of anecdote is data. And if that weren't the case, Google wouldn't work. Lilly said, it's obviously depression, not Prozac that's causing people to commit suicide, except they've got healthy volunteer trials, as the other companies have, showing people becoming suicidal and committing suicide on their drugs. They can wheel out experts to say these people must have had some other disease, and you can believe that if you want. But the key point is they're saying that RCTs are the science of cause and effect, and are you going to be the science or the anecdotes? And what I'm arguing, and Louis Lassagne would, is that the science of adverse effects is the evidence-based medicine you saw in the Teicher article, and what you're seeing here is an artifact. I've told you there was an excess of suicidal events in this article at the BMJ that's compatible with Prozac causing people to commit suicide. I've told you Lily cooked the books. When you uncook the books, it's a statistically significant excess of suicidal and completed suicides on Prozac. But the key point is, I've also shown you imipramine. There can be an incompatibility between what the controlled trials show and what the clinical evidence is. But an incompatibility like this is something that science thrives on. Lilly are not being scientific. They're being religious here. They're being dogmatic. They're saying, we're not going to try and solve what's going on here. You cannot make the claims that you're making. This is misinformation. It's not science. Only what we're doing is actually science. Science is, medicine is about bringing good out of useful poison. There's a good here in that people are getting involved in clinical trials on behalf of their families and friends and communities. Lilly are bringing a poison out of this good. The evidence-based medicine community, this is the article that establishes evidence-based medicine. The evidence-based medicine community that sprung up afterwards haven't complained about the ghostwriting of company trials, haven't complained about the lack of access to company trial data, but in particular, aren't complaining about this egregious breach of statistical methodology that we're seeing here. Now, I've talked about what is science, and the conventional view is that it starts here in 1660 in the Royal Society, where the guys are saying, we're not dealing with questions about the meaning of life. We're going to deal with questions that can be settled by data. Whether you're a Christian, Hindu, Muslim, atheist, or Jew, you've got to come into the room, see an experiment happening in front of you, and come to a consensus view about the best way to explain this. There's no statistics here. This is an event you've been asked to explain. Now, the usual histories emphasize the word data, although there's absolutely no kind of statistics here. The word settled is more important, as an event 40 years earlier may bring home. Walter Raleigh here is being executed for being too close to those pesky Europeans. It's kind of always the same in the UK. 400 years later, things haven't really changed much. But after he was executed, the English legal system figured there was an injustice here. He'd been executed on the basis of hearsay, that on the basis of things people said he had said and said he had done, but people who weren't prepared to come into court to be cross-examined. Now, let's say Lisa would have been much too young for me to have given her Prozac 33 years ago, but let's say I did, and after a week she came back to me and was saying, I'm feeling weird, I'm even thinking about trying to kill myself. The options we have will be to halt the drug and see what happens, maybe reintroduce the drug if the thing clears up. We could do lab tests and things like that. We could bring it along to all of you and have a case conference with all of you free to ask her whatever you wanted. And if at the end of all that, the consensus view is the best way to explain this is Prozac has caused Lisa to be this way. If we report it to FDA, the first thing FDA will do is to remove her name and remove mine and convert it into hearsay. If one of you has been put on a drug, or one of your children, one of these SSRIs during the course of the last few weeks and become suicidal, and you want to take a legal action against a company or a hospital or a doctor or whatever, and you say to the lawyers that there's tens of thousands of reports of people becoming suicidal on these drugs on FDA's website, you'll be told that's hearsay. It's not evidence. Nobody can be brought into court. In the same way, company trials come into court, but they're hearsay. We don't know any of the people who have been in these trials. We know that a lot of trials happen in the case of people who don't exist. We know that the authorship line of these trials doesn't involve the people who've treated the patients. They may not have seen a single patient. They don't have access to the data. They can't testify legitimately in court either. The only thing that would be pertinent evidence if instead of reporting to FDA, Lisa and I had written up her case in a good journal with our names attached to it, you could have brought both of us into court for a jury of Christians, Hindus, Muslims, atheists, and Jews to look at what we're saying and to work out what weight to put on what we're saying in terms of what has now happened to you. So here's Louis Lassagne at the end of his career, and just to repeat, there was no great logic to using RCTs. This is the man who's responsible for us using them. And he's saying in the 1950s, I was going around saying, you know, a day without randomization is a day wasted. But, you know, now I recognize, just like Tony Hill, that RCTs and evidence-based medicine give us average effects which tell us nothing about how to treat the person in front of us. And in particular, when they claim there are no adverse events on these drugs, they're just plain wrong. Now, here's a life expectancy curve in the United States. And the high point there is the early 1980s, when this idea is coming in that RCTs are the best way to establish what a drug does, both the good things and the bad things. And after that, one of the things that begins to happen is we begin to treat risk factors, giving drugs to healthy people on the basis they can do no harm. 20 years later, the word polypharmacy turns up because we begin to recognize people being on too many drugs can be harmful. 20 years after that, we've got a situation, this is 8 years ago, so things are worse now, where nearly half of people over the age of 45 in the United States are on 3 or more drugs every day of the year. And nearly half the people over the age of 65 are on 5 or more drugs every day of the year. We know that life expectancy is falling, plummeting, and this is before COVID. We know that reducing the number of meds you're on can reduce your likelihood of going into hospital, can increase your life expectancy, and improves your quality of life. The problem is, reducing medication burden is the greatest medical challenge we have now today. But getting you off all these drugs you're on, some of which can cause you to explode when you try to halt them, that is, go on to commit suicide or whatever, can't easily be done. It's a very tricky problem. The best evidence comes from the doctor having some clinical experience of this, but the really best evidence is the experimental apparatus in front of you is the patient. And this is an experimental apparatus that can talk to you and can tell you what happened when they missed doses of 1 or 2 of these drugs, what happened with the sequence of pills as they went on them, you know, to change the effects that these things were having. This is the best evidence we can have in terms of how to move forward. A relationship-based medicine rather than an evidence-based medicine. No RCTs are ever going to tell a doctor or a patient what to do in this situation, which is the most important medical situation we now have. There are never going to be any good guidelines in this area. The problem is the doctor is up against a fetish we all have. We all believe in numbers to the point where we've misapplied medical statistics in order to sort of try and give us a stop-go mechanism, because we're terribly nervous about the risks we're taking when we gamble on the drugs we give people. I don't think we should need a mathematics of individuality to tip the balance back so that we can take individual patients into account. But curiously, we have a mathematics of individuality, which has just appeared this year. And in the north of England, a man solved a problem people have been trying to solve for decades, which is there an aperiodic shape? That is an individual shape that when you line it up for 1 billion miles, there's no pattern that repeats. It turns out there is. Mathematics is not about numbers, it's about shapes and it's about concepts. And this is a shape which supports the mathematics of individuality. And the word Einstein means one shape or one stone. And the shape looks a little bit like a hat. So the guy used the term Einstein's hat for what's going on here. I'm not sure we need it, but we now have a mathematics of individuality that may provide a template for what I think is needed, something to support the judgment calls that we need when we're treating individual patients, something that will support a relationship-based medicine. Thank you.
David, thank you for this brilliant talk. So if you could close your slides, we can start with the question.
Well, give me just a moment to try and close my slides. Do you want them closed completely or just, yeah, we'll close them completely. Okay.
Excellent. Please raise your hands. David, I do have a very difficult question for you, but
yeah.
first, let others ask questions. So David, please go ahead. No, go on.
Yes, the question of individual responses is one that's been considered a lot by statisticians. Stephen Sen has written, for example, a lot about it. And it is only solvable by doing crossover randomized trials. You're quite right, of course, that an RCT, a plain two-group RCT, can't do it. But that's because it's not sufficiently statistically sophisticated. It's because it's not, yeah. So the one bit of convincing evidence I thought that you gave was the on-off, which is a sort of rather crude crossover experiment. But other than that, I mean, take statins, for example. Do you believe that statins, the side effects of statins, which have been shown to be very much the same in the placebo group as in the treatment group, do you think that's, do you believe that statins have terrible side effects?
Yes, I think they can cause very real problems. And I think the efforts to try and whitewash this are close to reprehensible. Let me make a point or two here. First of all, people need to realize that I'm not anti-medicines. I'm not anti-antidepressants. I'm very pro these medicines. I believe my job is, as the traditional wisdom was, to bring good out of the use of poison. And I don't think the statins are sacraments that can't cause problems. I think they're poisons like anything else, and they certainly can cause problems. I'll go a little bit further on this, which is that most of the material you've seen here, I've got from people who work within the pharmaceutical industry. The people who have been most helpful to me are people in the pharmaceutical industry who are concerned about what's happening, about the harms that have been done to people by denying that these drugs cause problems, which is what the companies do. They're in the business of trying to say that someone like me, who's trying to practice medicine and trying to let you know that if I give you a drug like a statin or an antidepressant, that we're dealing with a tricky problem here, which is we're trying to bring good out of the use of poison. The aim of the exercise, with both you and me involved, is to do that, to bring some good out of it. But that's going to happen if you realize that what I'm giving you is a thing that may seriously harm you. And I remember that as well. And that we don't go by what increasingly is a ghost-written literature, well, what is universally almost where companies are concerned, a ghost-written literature with no access to the trial data, and not even FDA have seen it. And in particular, I can line up much more medical experts, statistical experts on the side of the argument I've just made than Stephen Sen, whom I don't really rate as a good as statistical expert. What people like Sander Greenland are saying, who is rated by everyone as far as I know, and Ken Rothman, is the points that I'm trying to make to you, which is we're looking at compatibility intervals. It's nice if we can do a crossover trial in an individual, but we don't need that.
I'm afraid you do, you know.
David, we don't agree on this. David, we don't agree on this. And I think maybe if you want to move on from just that point, I mean, we absolutely don't agree on this.
Yes. Well, I mean, I certainly don't defend GSK. They were dishonest, but dishonesty is a different matter from...
well, what I'm more concerned about is, I mean, loads of people will expect the pharmaceutical industry to be scurvy knaves. What I'm concerned about is the cowardice of clinicians. That's what has me most concerned.
Okay, thank you.
Thank you, David, both Davids. So please raise your hand if you have a question. And let me ask my question. So David, Ian Hudson now is with Bill and Melinda Gates Foundation as an advisor. So if you could give Ian an advice, what should he do at the Gates and Foundation as a project, as a trial in his new role, to contrast to his previous?
Right. And Lisa, that's a terribly tricky question. As you know, Bill is a major supporter for the vaccine trials. And this is point where I think we can come back to Louis Lasagna. Actually, it's interesting. Today, the FDA are having a hearing on whether Pfizer's RSV vaccine is going to be approved or not. And this is a vaccine given to pregnant women. So this brings us right back to Louis Lasagna, and following a problem which is caused by drugs in pregnancy, he's introducing an efficacy criterion into the regulations. Now, the problem, I think, is, which I think Lasagna recognized, is that an efficacy criterion, and I would say that RCTs are a gold standard way to hide adverse events, as you've seen from the talk, but an efficacy criterion puts pressure on people, and in particular, this comes through in pregnancy. Women who are pregnant are going to be told this RSV vaccine has been proven to work. They're going to be shown data on their children and things like that who are coming in. Well, they'll be born during the RSV season. They're going to be told, you know, as a mother, you really need to get involved in these trials to help show that the RSV vaccine works. And then once it's on the market, you're going to need to have it. There's pressure on women, as I say, to take something like this, when in pregnancy, of all places, the thing that most concerns a mother is not the efficacy of a drug or a vaccine, it's the safety of the vaccine and the drug. And this is where Ian Hudson and Bill Gates and all of us need to rethink. It's great to have evidence that this vaccine may work, but in the trials that have been done of the vaccines, the safety element really has been discarded. And almost on a public health basis, it's almost like, well, if a bunch of people die in the vaccine, you know, we're not awfully worried about that. Anyone talking up about the fact that the COVID vaccines could cause problems found themselves, you know, very isolated and branded as a conspiracy theorists, which is just not right. That's not medicine. Medicine is about dealing with terribly tricky things, which does put pressure on all of us if we're going to gamble with these things to have as solid an evidence base as we can. And I think Ian and a few others need to rethink how much they've contributed to the safety evidence base being really solid.
Thank you. Since I don't see any other hands, I'll allow myself to ask another question. So
Sure.
I think with your talk, you brought yet another level of complexity to an already very, very difficult landscape. And personally, dealing with clinical evidence for quite a few years and seen many clinical trials, I'm very much pro randomized controlled trials. However, the bits that you brought forward very clearly show that we do have limitations, very important limitations. So how the message is packaged, we need to be very careful because we already see the world very much departing from RCTs. So, and again, psychiatry and many other clinical fields might be have particular features which differ, which are not maybe applicable in terms of adverse event profile, ability to diagnose, the soft or hard outcomes and in the patient. So my question to you, if you could imagine an ideal world, the resources are not a barrier, how should evidence building, let's take psychiatry, look like? So if we do have randomized controlled trials, what are the layers? Where can we bring the world to a better decision-making system to protect patients, but at the same time to get the things to them?
Yeah, we need to do a bit of thinking about all this, which is like Tony Hill, I believe in RCTs. I'm pro-RCTs. This is not an anti-RCT trial any more than it's talk than it's any more than it's an anti-drug talk. It's about, if you're going to play golf, you need 16 clubs in the golf bag. The RCT may be the best club and the one that you get furthest. I mean, it's you're the driver and gets your ball further than any of the other clubs. But if it's the only club you have in the bag, you're going to lose to a person like me who can barely play golf but has 16 clubs in the bag. So it's much more a case of recognizing that most drugs have, the latest estimate is 3,500 effects if you look at the epigenetics and things like this. randomized controlled trials, as Tony Hill told us, really only focus on one thing that the drug does. And the focus can be so intense on whether a drug is an antidepressant or not. And with this intense focus, what we've got is with RCTs, we can bring drugs that are barely effective, like the SSRIs. They're great anxiolytics. As antidepressants, they're barely effective. We can bring a drug like this on the market on a statistical basis without anyone seeing much benefit actually in the patients that get this drug. But the bigger point almost is this: while the focus on mood disorder rating scales and things like that in the course of the trial distracts from the fact that these drugs can also cause sexual dysfunction. Now, they cause sexual dysfunction in pretty well everyone that takes one. Within 30 minutes of your first pill, your genitals will be numb for most people. But yet, because of the focus on the mood effect, the companies were able to report at the end of the day that only 5% of people or less have sexual issues on these drugs. So the randomized controlled trial for SSRIs got entirely the wrong answer. These are issues about, can I make love, that in the case of people who are mildly depressed are much more important to them than, will this drug help a mild mood disorder that I have that's going to clear up anyway? So we've got a situation where randomized controlled trials are now used to get weaker and weaker drugs on the market, which is not what you want randomized controlled trials to do, which is not what I want them to do. Okay, and at the same time, they mean that we're less knowledgeable about what these drugs do than if we just given them in an uncontrolled way to a bunch of patients and seen, well, do they really work or not? And if they do work, what else are they doing? Are people going deaf, for instance, which Tony Hill's first randomized controlled trial missed?
Thank you. That's a very clear advice for merging RCTs and real-world evidence and pragmatic approach to generating the package for decision-making. So there's a question in the chat. So there's a comment from Hillary saying that there should be effective post-market surveillance, and followed up by a question from Caroline Struthers about why is it not done? Any comments on post-market surveillance?
Yeah, sure. No, I do have. And I should mention that I've got a big conflict of interest here to tell you about. I don't think leaving post-marketing surveillance to the drug industry is what we need to be doing. I think what we need to be doing is doctors need to wake up and realize that, you know, they are trying to bring good out of the use of a poison, and they've been complicit in saying these drugs can only do good. And this is going to put us out of business. And I like doing the job. I like treating people, and I like being able to use drugs to treat them and seeing when these things really work. A good clinician, though, doesn't just hand out drugs. They know when not to hand them out, but they also need to realize that if the drugs work wonderfully well as the companies say, and are free of problems as the companies make out, doctors are going to be replaced by cheaper prescribers, by nurses, by pharmacists, and others. So I think in terms of post-marketing surveillance, doctors need to wake up and smell the coffee and report to journals that these drugs can cause a problem, and here's the problems that I and colleagues have seen. And medical journals like the BMJ, which these days don't take case reports like this, need to wake up as well and realize that if they're really supporting doctors in terms of therapeutics, that they need to have reports like this in their journals.
I think
Yeah,
Jane
there's
had
another comment from Caroline in the chat. So basically reiterating that the surveillance should not be done by drug makers. That's quite clear. So regulators have the system, both EMA and MHRA have a very good system. The question is, does this work, and does this deliver?
Yeah, no. You do not want to leave the issue about the adverse effects of drugs to EMA or CDC or FDA or anyone like that. These guys who work in there are bureaucrats. They're in there often, if they've been medically trained, they're in there because they don't particularly like meeting patients. They prefer to deal with paperwork. It's, you know, and as I often say in talks, you can bring a bureaucrat to paper, but you can't make him think. in a clinical setting, it's the people who take the drugs and the doctor or whoever giving them the drug who are in the possession of the evidence. And they're called on to make a judgment under uncertainty about what's actually happening here. And this can be a critical judgment. If the person's feeling suicidal, doubling the dose of the antidepressant may kill them, stopping the drug may save their lives. So these are terribly important judgment calls to make, which bureaucrats can't make. And the extraordinary thing is, doctors, like patients, seem to think at the moment that FDA and EMA and MHRA are the people who work out whether a drug is actually causing an adverse event or not. If we've got an inquest where a patient's died, let's say one of your children has died, and there's an inquest about did the drug cause the problem, and the coroner is absolutely convinced it did, and he reports it to MHRA. MHRA will say, what did the doctor say? And the doctor will be advised by his lawyer to say nothing, not to say that the drug has caused the problem. So this is an extraordinary situation we're in where the public and doctors defer to people like FDA. In Freudian terms, this is what's called delegated narcissism. It's what we do when we're children. We think that our parents have the answer to all the problems of this life. And bureaucrats certainly don't have the answer to the problems of giving drugs to patients.
Very excellent summary, but at the same time, I think now I'd like to hear a bit more. How does your website for surveillance work, and how do you ensure this is a consistent and I want to use the word statistically significant, but how do you get enough of these reports to make conclusions? Because my understanding of pharmacovigilance through the regulators was the data collection function, where the judgments then could be, I mean, this data should or can be given to someone else, but I understand this bit that doesn't work. So how do you do it independently? And you already have experience with it. How do you convince, for example, a clinician in the UK knows that if something is wrong, there's a yellow card system and they need to go through MHRA? How do you make sure they go to your website or they go elsewhere to put this data forward?
Sure. Well, the problem if they go to MHRA is there's no names on the report. Drug companies were legally obliged, but they wriggled out of this. If you worked for one of at the drug companies and you were on a train or whatever and heard the person in the seat behind you talk about a problem on an SSRI, it was causing people to become suicidal, you were legally obliged to let the regulator know about it, but also legally obliged to get in touch with the person and get their medical records and interview them and make a judgment call about whether your drug had caused this problem or not. It's not a question of amassing hundreds of reports. FDA will amass thousands of reports till the end of time and never decide that a drug has caused a problem. It used to be the companies that said, well, we've looked hard to try and find any other way to explain this, and we cannot find any other way to explain it other than our drug caused it. And then they've put it in the label of the drug, usually under a heading of other reports, which is quite clever because people reading the label and the bit about other reports assume, well, these are reports they've got from the Church of Scientology and flat earthers and things like that. And they're wonderfully transparent, letting us know they've had these reports, not realizing that things only end up in that bit of the label when the company has tried as hard as they can to disprove that their drug has caused the problem and is now putting it in because they can't see any other way to explain it. And this comes back to the point I'm making. And Louis Lasagna made and Tony Hill made, which is the right way to decide if a drug is causing a problem is the person treating the patient and maybe calling in other doctors and other patients and doing the lab tests they can and having a case conference with all sorts of people like David Colquhoun who may not believe that the drug could be causing a problem, free to ask any questions they want. But everybody under an onus at the end of the day, including the pharmaceutical companies, to say, look, in this case, it looks like the drug has caused the problem.